Thank you very much for joining us today to hear about the latest clinical practice update on pain management in inflammatory bowel disease. My name is Emeran Meyer, Distinguished Research Professor at UCLA with a career-long interest in brain-gut interactions and chronic visceral pain. I'm director of the Oppenheimer Center for Neurobiology of Stress and Resilience, and I'm joined by one of my co-authors, internationally renowned pain behavioral expert, Dr. Laurie Keefer, from the Division of Gastroenterology, Econ School of Medicine at Mount Sinai. Our other co-authors are Dr. Jana Hashash and Eva Shigetti. Dr. Keefer, can you just explain briefly what chronic pain is in IBD?
Sure. Yes. Thank you, Emeran. I think it's, for the IBD doctor working with a patient who may otherwise look like their inflammation is under control. It's really hard to tell that difference between acute to chronic pain. But when we're talking about chronic pain, we're talking about pain that kind of persists well beyond the time that you would expect it to after tissue injury or inflammation. And certainly, as you know all too well, that sort of the level of brain involvement becomes dominant in the experience of pain. And I always say to my IBD colleagues, just like you're managing inflammatory bowel disease, chronic pain itself is also very episodic, fluctuating, and is related to a wide range of biological and environmental triggers.
But I think there's a emerging consensus really around the role that with chronicity of pain, there's what's been called a centralization, a movement of the mechanisms to the spinal cord and to the brain in maintaining this situation. And the way we understand it today is really that the pain has multiple pain modulatory mechanisms. It can inhibit pain very effectively, but it can also facilitate pain and increase the pain perception, both on a sensory level, but also on an emotional level.
That's right. And I think when we look at some of the risk factors in IBD for developing chronic pain, right, we're looking at people who maybe have a history of chronic pain or central sensitization, other kinds of painful conditions that they may be struggling with. Patients who've had prior early life adversity or trauma, including discrimination experiences and poverty, patients with poor coping, catastrophizing, anxiety, depression, all those prior negative experiences that really make the brain, make it harder for the brain to disinhibit those signals arising from the gut.
Important to realize we are beginning to understand the biological underpinnings of most of these mechanisms. So this is not something different from medicine. This is core biology. This is, it's just not been taught in medical school. And I think it's important for the practitioner to realize if somebody has chronic pain, it's not just a psychological issue, it's a biological problem. So given this new insight and recognition, what's the most effective therapeutic approach to patients with chronic pain in inflammatory bowel diseases?
So one of the things we focused on in this CPU was really a practical approach for the physician, right? And so beginning with really listening to the patient's description of their pain, the quality of it, the intensity, the location, how they sort of interpret it and how they cope with it. And that really should inform the provider as to the level or degree of integration that they may need, right? Ranging from sort of, some basic brain gut behavior therapies focused on visceral hypersensitivity, all the way up to really integrated, perhaps substance abuse treatment for patients who might have been prescribed opioids, to sort of things in between, neuromodulators, that type of thing.
So for the practitioner, the clinician who sees a lot of IBD patients, listening to what you just said would seem like this is really out of my range of expertise. Who should be in charge of delivering this multidisciplinary therapy?
That's a great question. So I think that the gastroenterologist is really pivotal in this integrated care program. They are actually just adding on to the team of professionals that are taking care of the patient. It's really important that the gastroenterologist does not abandon these patients. In fact, a lot of times when they're referring out to a gastropsychologist, to a physical therapist, to a support group or a digital therapeutic, that they are still telling the patient to go out and try these things and come back and report on how they're doing. I can't stress that enough. Patients don't want to be dismissed with chronic pain, and that doctor-patient relationship is really, really critical. And so the gastroenterologist might be outsourcing some of these interventions, but not leaving the patient to their own devices.
One of the concepts in our CPU that we emphasize is the best approach is to bring up the integrative care model from the beginning and not, just rule out anything biological or physical that may be wrong, and then at the end send them to a psychotherapist or behavioral therapist, but include this from the beginning in the model. So the bidirectional interactions of the brain with the gut are essential. I mean, that concept, I think, is sort of really that has changed the field and has helped a lot of patients to deal with this more effectively.
That's exactly right.
Are there any ways of determining if a patient may benefit from integrative pain management care?
So first, I think everyone probably could benefit from an integrated approach to pain. Anything you can do to distract yourself, anything you can do to keep your body calm and at a lower arousal level is really going to help you manage chronic pain, right? I think when you're listening to the patient, if you're hearing evidence of them sort of talking about feeling helpless over pain or feeling that the pain is unbearable or something that they really are not able to regulate on their own, that's when you're really starting to think through some of these behavioral interventions that really kind of teach coping strategies to be able to feel a little more empowered. Maybe they need some help accepting that pain may continue to occur for them, but that they can live their best life despite it. Again, those are all strategies that are taught in a lot of these behavioral interventions. Many of these other interventions, things like acupuncture, massage, exercise, relaxation, mindfulness practices, are also really good lifestyle practices for IBD patients, let alone for ones that have chronic pain. And I'm a big fan of encouraging those as well as part of just overall building resilience and reducing stress and arousal, which obviously amplify pain.
One issue that we're always running into with any kind of therapeutic approaches that do not just simply involve swallowing a pill or getting an injection is compliance. And have you found in your practice, I mean, you've seen hundreds of patients and proposed these kind of behavioral approaches, have you seen that compliance is a barrier, is an obstacle?
Absolutely. I mean, I think when you're in pain, it's hard to initiate anything. It's hard to take on one more responsibility, right? My patients say, why do I have to manage this too, right? Now you're telling me I have to go and do this much more treatment. But I think it's really comes down to what you were saying about that understanding the brain gut connection, understanding that while we may not be able to change certain anatomical or inflammatory or bowel wall damage at the level of the gut, we still have the ability to change things at the level of the brain. And that's really, that buy-in that comes from the gastroenterologist that teaches the patient that they do have some control, even if it's not the thing that caused their problem, the thing that may be making it worse or keeping it going is something that's modifiable through integrated care.